So good afternoon. Welcome. We appreciate you all being here this afternoon. And we're going to talk about a subject that obviously is on top of minds of most people, whether they're policymakers, practitioners, patients, etc., innovator companies, payers, managed care companies. And that's the whole issue of integrating value considerations specifically in care decision-making processes. And so we have a great panel today. I'd like you to very briefly just introduce yourselves, left to right. Dr. Malin, just start quickly, please.
Thank you. I'm Dr. Jennifer Malin, and I'm Medical Director for Oncology for WellPoint.
I'm Doug Blaney. I'm a medical oncologist, former ASCO president, was in private practice for 20 years, and I'm currently a medical director and a professor at Stanford School of Medicine at Stanford.
I'm Barry Fortner, president of International Oncology Network Solutions.
So we have a great group, a lot of experience across probably almost every stakeholder group in cancer care and the cancer care delivery system. So I started out by going back to some venerable health policy experts. One, Noah Webster, and George and Charles Merriam of Merriam-Webster fame. And so I just looked up care, and this is going to be nothing surprising. And basically the definition is things that are done to keep someone healthy and safe. So pretty simple. And then I looked up value, and there are different bullet points. They were not in bullet point format, but the three said the amount of money that something is worth. Secondly, something that can be bought for a fair or low price. And one that had nothing to do with money, usefulness or importance. So kind of moving into the value equation we had, or discussion, we had two or three definitions obviously focused on cost or price. And we had one at the end that just was usefulness or importance. So, Dr. Blaney, when you sit down with patients and caregivers in the clinic, in your office, I mean, what do patients want? They're newly diagnosed. What do they want? What is your interpretation of what they value?
Well, so most cancer patients, the first thing, whether it's spoken or not spoken, they want to know, am I going to live or am I going to die? Sometimes they'll enunciate it very clearly, but most times that will be the focus of the conversation. So I'm there to be an expert solution provider to them and say, here's what we know about your illness, here's what we know about you, tell me some more about you, and how can we get you to, if you are going to live, how can we get you to get you there most expeditiously with minimal interruption in your life. If this cancer is one that we can't cure, how are we going to get you as long as possible with the best quality of care and the best, more importantly, the best quality of life? And that comes back to what's most valuable and most, to use the Webster term, most useful to you. Earlier, and I believe it or not, I keep in mind the equation that we saw earlier today, which has value as quality over cost. So if we can say we deliver high quality care at some cost, that is a construct many people are comfortable with in their daily lives, whether they buy a car or buy a pair of shoes. Shoes are not, they're a consumer good, but they're really a solution to a problem. How do I protect my feet as I get through the day? So so you can use value for shoes, cars, and cancer care, actually.
So you're at one of the leading cancer centers in the world. So is your patient, and you're also outside San Francisco, is your patient population, I mean, different? Do you know, obviously well insured, et cetera, et cetera?
Yes, they are, but I was in the private practice world, and I was at the University of Michigan for 7 years also. And in the private practice world in the eastern part of Los Angeles, people may not be as articulate, they may not be as internet savvy in that part of the world, But deep down inside, they do have this visceral notion of, am I going to live, am I going to die, and how can I do that, and how can you get me through this problem?
Okay. So Dr. Malin, you're a practicing oncologist. You're a medical director for either the first or second largest managed care company in the United States, therefore the world. You've worked in the pharmaceutical biopharma industry. You either have been or certainly presently maybe at RAND, UCLA, et cetera, kind of definitely in the health policy field. So you cover almost everything. So, but let's focus on WellPoint/Anthem. In terms of, you know, your company promising or saying to its beneficiaries, we want to bring you the best value in healthcare. And obviously we're talking about cancer care here today. When you go to work every day, what's on your mind in terms of, you know, and this isn't day by day, but how you're going to fulfill your company's promise to its beneficiaries in terms of cancer care, that you're going to bring value to them. So how do you interpret value from the perspective of, you know, your beneficiaries, those who have been diagnosed with cancer, those who might be at higher risk, the whole continuum, if you will. So just kind of what's your gestalt going to work every day?
Well, I think, so sitting at a health plan, we really think of ourselves as having to keep in mind the needs of all of our stakeholders. And so first and foremost in this situation, it includes our members who are diagnosed with cancer, but then we also have to think about all of our beneficiaries in terms of, you know, are they going to be able to keep paying their premiums next year? And then what people's co-pays are going to be this year as they get care, you know, what their out-of-pocket maximum is. And then lastly, we do not deliver the care directly ourselves, so we have to make sure that our providers are able to provide good quality care, that they have enough resources, that the contracts are fair. And so it's a lot of balancing, and it varies region by region. But I would say, as I think about it day to day, my focus being specifically on oncology solutions for WellPoint and Anthem, is how can I develop programs so that I can assure our stakeholders that our members have access and are getting the best quality care and the best value.
So as a practicing oncologist, as someone who's gone through the extensive training, obviously, I mean, how do you address the issue and the balance, if you will, of not wanting to, well, maybe even step on your own toes, but step on Dr. Blaney's toes? You know, he's had a fair amount of training and experience, so the issue becomes is, you know, there are these hosts of programs out there, and, you know, what do they add? You know, what are you trying to add to facilitate better decisions for individuals who are highly trained and obviously may have years of experience like yourself?
Mm-hmm. Well, I think there's a variety of resources out there, and so we're certainly not trying to replace resources like NCCN guidelines and ASCO and all the training people have had. But one of the things that we've been doing is implementing as part of our cancer care quality program our cancer treatment pathways. And part of that, I think, is the educational value. I've been surprised as I've gone to speak in front of groups like this and showed them the thought process that goes into developing pathways. And if you look at the different regimens, say, for example, for metastatic lung cancer, 4 cycles of carboplatin and paclitaxel is about $450. At the other extreme, 4 cycles of carbopemetrexed and bevacizumab is $65,000. And amazingly, that's, you know, there's not really any difference, you know, in the outcomes, yet there's a huge difference in the cost. And surprisingly enough, many physicians are not aware of that. So there's an educational value to putting pathways out there. We've put ours out there on the web. They're transparent. Anyone can access them. And at the same time, we are changing our reimbursement model so that practices who are who choose for an individual patient to put that patient on a pathway regimen are able to bill for additional reimbursement for treatment plan and care coordination. And this is because we recognize that in today's world, we have been largely paying for all of the care coordination that goes into caring for patients with cancer, somewhat through the E&M codes and kind of what we went to medical school to do, but largely through the margin on drugs. And so if we're going to expect the community of oncologists and providers who are caring for our members to be value conscious, if they're going to be selecting more cost-effective regimens, we know that that's going to decrease the revenue to their practices, and they aren't going to be able to support their operations. So this additional reimbursement is designed to offset loss of margin that they would experience by practicing more cost-effectively.
All right, so we're going to get more into that in a few minutes. Dr. Fortner, so you've been a pioneer in the area of metrics, measurements, establishing specific metrics to, help policymakers, program developers better understand, again, what providers are interested in, what patients are interested in. So, how do you really go about that? Is it kind of a simple thing, or, are there programs out there that you've developed or that are available to help elicit and describe very specifically what patients value in terms of the cancer care they seek?
There certainly are a lot of efforts going on and have been for decades to try to bring the patient's voice into the equation. Incredibly complex. And frankly, sometimes we talk about value as though it can be reduced to a formula. And in many ways, the essence of being a human being, part of that essence is an irrational desire to live. And our equations sometimes fail to reflect the matrix of things that make up an individual person when they sit with a physician and they weigh this very sacred decision. I consider that a very sacred space when they're making a decision about to treat or not to treat, or the place of treatment, or clinical trial or no clinical trial. And now we're bringing into this already complex decision set an issue of cost and whether a decision in one direction or another is worth it. It's a difficult thing, and I've been on both sides of it. I'm a clinical psychologist, and I tend to see patients, when I did practice, when there's discordance between the physician and the patient. And that's on both sides. Patients not wanting to pursue treatment and the physician wanting them to, and physicians recommending that they go into palliative care or hospice and the patient not wanting to. And the way that plays out is a very idiosyncratic narrative. And it has to do with an individual's life and where they are in life. Again, what they value, what they're willing to risk, what they're willing to consider, what their family's willing to consider. So the short answer to your question is that there are many organizations that have satisfaction measures that are now even pursuing patient value indices. I think, though, that as a science, we still are struggling to represent the vividness of an individual person's perspective. And our metrics, measures of central tendency, means, medians, standard deviations on some rating that a patient gives, unfortunately for me, fails to reflect the colorful nature of what it means to be a human being and to sit with a physician and ask that question, am I going to live or die?
Yeah, you brought back to me remembrances of being a poor PhD at Aetna running national coverage policy, but somehow getting involved in, I'll say thousands because it was over my 6 years, of cases where you could see yourself, your mother, your brother, your sister in the cases. And the issue that you go back to is, can I live with a process that I set up at this company if one day it were one of them that the decision, about access to care really relied on the process I had set up. So it does hit home. Let's move on to, okay, so all the pathways at WellPoint, Anthem, what's the right name these days? Because
It's in flux.
it's in flux, okay. 'Cause-
I think in several weeks it'll all be Anthem. Right now we're still
Okay.
WellPoint officially.
Okay, so your programs right now, well, I'll let you answer the question, seem to be focused on drugs. Certainly the pathways are. But if you look at United, in their 5 to 6 year pilot project on really trying to reduce the costs of drugs and biologics in cancer care, and coming up with a surprising result that, well, our estimates of what our drug costs were going to be, we actually have threefold the drug costs, yet our big savings are in ER visits and hospital admissions, which has been shown many, many times, Sprandio, certainly with patient-centered medical home, et cetera, et cetera. So in terms of technologies, what do you think, are you focusing on everything? Are you looking at radiation modalities? Are you looking at imaging techniques, et cetera? So what do you...
So we have a phased approach. So imaging management has been something that's been long-standing, I think, for most insurance companies, including ours. We have a subsidiary called AIM Specialty Health that already does imaging management across the board for high-tech imaging. When we looked, I can't speak to United's costs or experience, but when we look at the costs of treating patients with cancer, and this is all patients in active treatment, not just those getting chemotherapy, a quarter of the cost is for chemotherapy and supportive care drugs. It is the single largest cost, bar none, for cancer patients in our health plan. And it is the fastest growing area. Specialty pharmacy, drugs, and oncology are increasing at 25% per year. So it was clear to us that we had to focus on chemotherapy and systemic cancer therapy first. The other reasons we focused there first was because medical oncology practices have been struggling, as you know, and so we wanted to figure out a way to help support community oncology practices in a way that would also meet the value equation at the same time. We are going to be looking at these other areas that you highlight and folks like John Sprandio have been working on. As part of our quality program, we will be creating reports for practices that participate in our network, and it will not only include their adherence to evidence-based care and pathways, but will also include for them what the hospitalization rate and ER utilization rate for their patients on treatment has been. So we don't currently have any pay for performance or anything tied to that. We want to give our practices time to get used to the data, to give us feedback, but we envision over time that will get incorporated into the program.
So just a quick question in terms of kind of measuring quality of care based on adherence. I mean, I think your pathways are easier in the sense that obviously it's tied to reimbursement. You have forms that have to be filled out. But I mean, your claim systems don't have enough data to allow you to evaluate quality of care because you don't have stage.
Well, so through the program, we are collecting stage and biomarkers. So we will have that additional data through the program to be able to assess quality in a broader way.
Okay. So
Can I
please.
comment?
Yeah,
so
please feel free to.
Was Lee Newcomer invited me to have an early look, me and some others, an early look at the project that was alluded to earlier with the 5 practices. And it came up early in the discussion that the practices that participated had a real difficulty telling who was a United patient and who was an Aetna. Right. So that took several years to get going, to be able for the docs in the practice to say, oh, this is going to be a United patient, I have to do this and I'll get reported on for this thing. I think the issue that came up earlier today, that's in stark contrast where I used to be in the state of Michigan, where there's a majority payer there that when they put in a program, most everybody pays attention because they have 80% of the commercial market there. So it's a little easier in some states to put these in place. In California, at Stanford, our market is so fragmented that it's very difficult to, what's an Aetna or WellPoint or whatever it is, and what's a United, and what's a Blue Cross, and what's a Medi-Cal, and or Medicaid, which is what we call it, or we call it Medi-Cal, and what's a maybe a Medicare or a Medicare Advantage, or this fragmentation is, I think, going to be a thing we'll have to deal with.
Yeah, I want to talk about this a little bit more, and you brought it up earlier than I was going to go to it, because, you know, I'm getting old, as everybody can tell, and so the issue is in 1987, Wenberg published, you know, the famous variation studies, where if you lived in Boston and you had lower back pain, you were 4 times as likely to have a laminectomy than in New Haven, both academic-based kind of delivery systems, if you will. And this led to the whole call for guidelines or whatever to help decrease variation in care. But what you just explained seems to me that we've got this plethora of guidelines, pathways, protocols, coverage policies, step therapies, et cetera, across the board. And you at Stanford, and Barry, I want you to comment, you too, Jen, but, you know, I mean, are we basically kind of shooting ourselves in the foot? We've got the Anthem, we've got the United, we've got whatever it is, Technology Assessment of California, we've got NCCN, ASCO is going to have value scores. I mean, it's like you know, getting to be, we have our Tower of Babel almost, but your perspectives on that.
Yes, so I think our hope is that technology will get us part of the way. You know, when I go to the got at the airport, I could go to the ATM, and it didn't matter if it was Wells Fargo, Bank of America, Credit Union. My ATM card worked because there's a common interchange of dollars, but there's a common interchange of data structures. We're certainly not there in cancer, and we're not there in either outcomes or clinical information.
But the issue with technology might be, well, you know, you're always going to get American dollars, hopefully, out of that, you know, but it doesn't like say, okay, this one's going to give me yuan from China, and this is going to give me lira from Italy or whatever, whereas if you have different pathways or guidelines or protocols from different entities, including Stanford, which probably has its own, you know, you may actually be limited to different choices.
I think some of that, honestly, is overblown. And when you look at the different pathways, there's very little difference between them. And even when there's differences, the number of patients that would actually apply to, and when you figure that most pathways, you know, adherence is 80 to 90%, I find it hard to believe that if you picked one good evidence-based, value-based pathway, you would not probably hit 80 to 90% on any of them. We are making progress, though, on the technology piece. We've been in discussions with several of the electronic health record providers. And, you know, like if I want to prescribe for formularies, one of the tools I have is Hippocrates. And if I look up an oral drug on my phone, it'll tell me which health plan's formulary it's on and at what level. So the EHR companies, I think, as a first step, there are several that have already agreed to have a feature within their EHR that lets you know which health plan's pathways things are on, if you want to get down to that level of granularity. And we're in discussions and anticipate that by the end of next year, we'll have our AIM platform integrated with 2 of the EHRs so that you'll have bi-directional connectivity and won't have to enter it into the web portal. So I think, you know, everyone recognizes that there are these challenges. But again, I would be shocked if you just picked one value-based pathway that really was truly evidence-based and value-based if you didn't hit 80% on any of them.
Yeah, it still leaves a lot of patients. But Barry, so you do a lot of analyses, obviously, your company that you run. A lot of analyses, I'm sure, for biopharma companies, for other entities, et cetera. I mean, do you see kind of noticeable, maybe regional differences or any differences that are perceptible that, you know, you might attribute, okay, so we're in the Pittsburgh, Indiana axis, so therefore we are, you know, we've got the VIA pathways in effect here, and all over the country we have WellPoint, but I mean, do you pick up anything like that or any signals? Or
There are definitely regional variations in cancer care, and frankly, there is variation in cancer care that none of us are comfortable with. And I don't think anyone disagrees that consistency, quality, better outcomes is not the goal here. I think the debate is over how we go about getting to the next stage. And one of the concerns that I have now is over the principle of physician autonomy and patient choice. And I fear that we are sacrificing physician autonomy and the profession where we hold the oncologist with the patient to be the central decision-making locus. We're sacrificing that as we try to achieve these other things. And I believe that the information revolution is at hand for medicine. It's not here, but it is at hand. And we're very close to being able to see things in ways that we've not been able to see them. Across the country, I refer to this as the Siri rule. And I think we should not be designing programs that does not assume that we are close to a future in which our patients, our customers, our employees, our mothers and our fathers and sons and daughters are going to be able to ask Siri, would I have lived longer had I had another plan, another payer plan? Would I have lived longer had I gone to another institution? Would I have lived longer had I been employed by someone else? Again, we're not there yet, but we're close. And in an effort to get to greater consistency and better quality, I'm afraid that we are moving control of oncology from the physician to entities that are, in many ways, middlemen.
What do you think, Dr. Blaney?
Well, we're in a transition stage. The analogy I use is the airplane that many of us flew here today. There's a professional pilot up there who is a highly trained individual who's trained and capable of dealing with the vagaries of nature. But that airplane has, when he turns the stick to the right, the airplane goes to the right. When he looks over there, there's the altimeter, so he knows. So standardization, as both of you have said, is important. The problem, Barry, I think you're alluding to, is the fact that I'm turned into a data entry clerk. Every clinic I have to spend 2 or 3 hours at home catching up, entering, clicking, doing all this data entry. Whereas I'm trained as all of us are, to deal with the vagaries of nature that patient shoves at me, who their values, their family support, their finances, and where they are in their life. That's what I'm trained to take into account, not be a data entry clerk. And I resonate to the fact you think a lot of that function has been taken away from me, and we need to move, and we need to move so that we're across the table from a patient, not across the table from a computer.
Yeah. It was interesting. There was a great letter about 2 years ago from a physician in New Jersey to the New England Journal, and this physician was lamenting, I spend so much time trying to fulfill the requirements for meaningful use. I have no time for meaningful interactions with my patients. And, it is interesting. So, yes, please.
I definitely agree with the operational component, but I would press a little bit here that there's a deeper principle, and it really is about the decision process and how we do winnow through new products and new procedures and even error rates in the system that produce unnecessary costs to society and to an employer plan or to whatever level of person paying for the care. We sometimes approach this conversation as though we're at a point in cancer care where we can just stop and choose the least costly alternative. But we're not
actually
there.
talking about choosing the least costly alternative. I think what people are talking about is if you have regimens that produce the same outcomes. I think my patients, if there are two, I drive a Volkswagen Beetle. If there are two Volkswagen Beetles in front of me, and one is being listed for $50,000 and the other is $25,000, I'm going to take the $25,000 car. And I think our patients expect us to be making that kind of differentiation. There's a lot of people out there that try to encourage and get brand recognition for more expensive therapies that don't provide any additional value. So no one here is talking about stopping innovation. What we're talking about is rewarding real innovation, making sure that those therapies that really do provide 6, 12 months improved life, or ideally a cure, get rewarded, and we don't see continued escalation in cost for therapies that provide no benefit compared to what's already there.
Yeah, it's interesting, but I'll throw out, there have been like, and I think it's just one study, non-small cell lung cancer. We apply our pathway to non-small cell lung cancer first line, and we reduce costs by 35%. I mean, obviously, that's a U.S. Oncology study that was published, and obviously P4P pathway study that was published specifically. And it just seems to be, I think they're separate studies, but they're almost no-brainers. Yeah. If we push to generics, we're going to save 35% or whatever.
But it's not generics. I mean, it's a common treatment with oncology. Generics are the backbone of almost all regimens. So we treat people with generics almost no matter what we're giving them. The issue is what we give them on top of the generic and what choices we make and how we sequence therapy.
I think maybe a subtle difference here is that I'm agreeing with the scenario, Dr. Malin, but I believe that the market would eventually arrive at a conclusion, a competitive conclusion, in the context of information and transparency, where the consumers could make that decision with their physician without us preempting the process of that happening.
Nothing's preempting the process. The pathways are transparent. The patient can still pick a different therapy. All this is adding additional information into the process.
And I think that's where ASCO is trying to go. On the one hand, there's clearly high-value treatments. I think you could probably name them on one hand: imatinib, tamoxifen, Herceptin, rituximab, maybe a couple others. No one would argue that those are high value. You might quibble about the price, that they're too high, and perhaps they are. But that's one end of the spectrum, that there's really high value to those treatments, and others would name a few more. On the other hand, there are very low value things that we do, and that's what the American Board of Internal Medicine Foundation, with their Choosing Wisely and ASCO's contribution to that, to our top 5 in 2012 and 2013, are meant to provoke a discussion. And I use those every day when I sit across the table from a patient. My professional society says that PET scans for women with low early stage breast cancer are of low value. Our experts have looked at that. That's really low value, and it's, in my experience and my profession, it's not worth doing. Surveillance CAT scans for early stage cured breast cancer, again, not worth doing. So a professional society, I think, can call out some of those low value things. Where we're muddied, and Dr. Malin gave a good example, is in the middle with the lung cancer therapy. Since there's a third party, it's a socialized or a cost that's not borne directly by the patient. A lot of people will have their agent, which is me or Jen in her role as a practicing doc, make a choice for them. We're getting more with copays, so patients are having to become involved with copays, but we don't do a good job of, I think, discussing copays with patients and how much this is really going to cost. So in the middle is where these medium value and there's a huge splay, as Jen pointed out, in the cost of these chemotherapy drugs.
So let's get into ASCO clinically meaningful outcomes. I mean, the impact of that. So just kind of a quick perusal of NCCN guidelines, major cancer types. There probably wouldn't be much of an NCCN guideline left if, ASCO clinically meaningful outcomes came out 5 years ago when we were applying, 10 years ago even, applying them to entries to the NCCN guidelines. How do you think and again, for those of you in the audience, obviously this is the project by ASCO, and you're a former president of ASCO, Dr. Blaney, so keep me on track here. But a program that's aimed specifically at the design of clinical studies and setting thresholds, if you will, for what should be the objectives for attainment of improved outcomes, specifically focusing on overall survival and a little bit on PFS, I think. So The issue, though, is, so for non-small cell lung cancer, the expected improved survival should be between 3.25 and 4.0 months. So how should a managed care company apply that? You're a clinician. I mean, should they say, okay, that's the, hey, if it's not at 3.25 months, it's not gonna make my pathway.
But
No, I want to hear the. I want to hear
okay, so
and then you're going to get your time.
I'm not sure that I can fully buy off on that. I think I would start as a point of departure that we all have participated in clinical studies, and the 3% or 4% or whatever it is of patients who enter clinical trials in this country are not representative of those, are very few, poorly representative of those other 97% that we see day to day across the table. And there are, so that's one thing. Secondly, many of us have been involved with advising pharma companies on how do you get on a strategy to market an unmet medical need. What's the unmet medical need here that gets you to market most quickly, not what's going to produce the 3.5 or whatever it is percent improvement. That's going to come later, and hopefully in this era of big data, ASCO's CancerLink, which and some other, ASCO's standing up a CancerLink, which is a way of agglomerating big data. There are certainly commercial competitors out there, can help us get drugs to market and then see how they're used in everyday practice. And as Dr. Fortner points out, when we have a closer to perfect information, we can actually then say, okay, let the market decide. Interferon is not the best treatment for melanoma, may not be the best treatment.
So I'm going to go to Dr. Malin and Dr. Fortner, but I'll show you my level of sophistication. So when I saw the first draft of this, to quote the dog on the Jetsons, I said, ruh-roh. You know, we have an issue here, because this is aimed at the design of clinical trials. I understand that. But I said, uh-oh. You know, we're setting thresholds now that payers can use. So what's your view?
I was going to say, I don't think the way I interpret what ASCO wrote, it was not designed for payers.
It wasn't designed, but will payers use them?
I don't think payers will use them, and I think it will speed innovation. I mean, if you look at, you know, I spent 2 years, as you mentioned, working for a pharmaceutical company. The bar essentially for what your treatment is set is what you're trying to achieve is set by your power calculation. So if your power calculation is set to say, well, if we achieve a 3-week improvement in survival, then you're gonna, you know, if you meet that, you've succeeded, the FDA gives you your approval. But guess what? How many patients does it take to find a 3-week improvement in survival versus a 3-month improvement in survival? If we had our studies designed to achieve clinically meaningful outcomes, drugs that didn't meet those would fail fast, and we'd really get innovative therapies to our patients.
So you don't think payers, and I used to run national coverage policy at Aetna, so actually who's Jen Malin here? You guys all came in, we had already started. So Jen Malin here, obviously, I was going to say it's obvious, but from WellPoint Anthem and a number of different venues, Dr. Blaney, Stanford, and Dr. Fortner from Ion Solutions, just to make sure everybody knows. So what's your view of it? I mean, again, we know the purpose and we know the stipulation. I know ASCO kind of repeatedly said it because, quite frankly, they got absolutely hammered in terms of, you know, the feedback specifically. So I mean, how do you think it'll be used? Will it be used as a say, yes, and it can make a contribution to the expedition of technology transfer, but how do you think it's going to be used in the real world, and what do you see?
Well, I don't think any pharma company launches a phase 1 study hoping that they'll have a minimally or just a statistically significant effect. I think they all aim to have a new molecule be an innovation that's a leap forward. The process to getting there is something being discussed, and hopefully we can make that cycle much shorter, and they can, as really science is about eliminating less likely possibilities in a direction than it is about finding the positive ones. The elimination process is perhaps more important than the process of making an assumption of a causal inference. I think the concern is about being descriptive versus proscriptive. This debate is going to continue. You know, there were only a few years ago we were really fighting about progression-free survival. But I'm now on advisory boards where we're having very negative views of clearly statistically significant effects on survival. But 1 month is maybe not good enough now, or 3 months is not good enough now, depending on the category or where it is. And then even if it is an advancement in a disease category that hasn't had approval in a number of years, depending on the price, we might say that survival is not enough. So this is an evolving debate. And I guess I appreciate the debate, and I believe in the debate as a process that will move us where we're going. What I fear is that debate being squelched, one by bodies that might assume that they can paternalistically prescribe those decisions, or by a research recession that would take away some of the options for us to even debate about.
Yeah, Doctor.
I think as every disease becomes an orphan disease, I mean, I gave this lecture on breast cancer the other day, which, you know, most common cancer in this country. Everybody in this room knows how to treat it. Many be affected, but when I started, it was 2 diseases, ER positive and ER negative. Now it's at least 4, and pretty soon it's going to be many orphan diseases. We cannot, and if the more driver mutations that are discovered in a triple negative breast cancer, the more inhibitory tyrosine kinase or other things we're going to have to prescribe in order to try and treat or cure that. We can't afford 5 or 6 simultaneous $10,000 a year drugs. You know, as Herb Stein said, things that can't go on forever don't. So at some point, we're going to have to come to grips with how do we deal with 2 or even 3 $10,000 a month drugs that may work and may need to be used for a long time. That's
Well, I
going to
mean,
be a
if I were a
problem.
pharma company and I were looking analytically, I might say, or strategically rather than analytically, I might say, hey, I can hit that 3.25 months with a combination of 3 agents, and therefore I'm basically tripling. I mean, how do you view that? I mean, do you think, you know, I mean, that's potentially a way to actually hit the 3.25 month threshold and say, yeah, we hit the ASCO threshold, so we're definitely clinically meaningful now.
I don't think ASCO is being prescriptive about how you get there. They're just saying that, you know, I mean, I'll give you another example. When for my days working at a manufacturer, there was a drug that was approved that actually to this day is the only one I think that actually has the mean improvement in survival in the label instead of the median, and this was panitumumab. And panitumumab was approved first and 3rd line for colorectal cancer. The median improvement in survival was 1 week, and the p-value went out 5 places. I would argue that that was a misuse of resources to put so many patients on a trial that a 1-week improvement in survival turned out to be that statistically significant.
Mm-hmm. Mm-hmm.
So, not hard to argue with that, but as we get more personalized and more targeted therapies, hopefully that will that there'll be less patients needed to prove of that magnitude. But it means that those development costs are going to have to be amortized over a smaller number of patients.
And so this is where we're going. I'm going to go to Barry after I go to you, Doug. But so you raised the issue. So you have your pathways, and all sorts of people have pathways. And I wish I had a company that I could have sold for $517 million like P4 did to Cardinal, but that's another story. Pathways and protocols and things like that. So in 5 years, is there going to be a need for NCCN guidelines or Anthem pathways or the next generation sequencing interpretive reports going to drive with their recommendations about what the appropriate regimens are? Is that going to happen in 5 to 7 years?
When I was ASCO president, I sort of said 2 things. One, pathways are going to be generic before too long. So they're going to move.
What do you mean by generic?
Cheaper? Everybody has a pathway. No one's going to get 517 or whatever the number you quoted for a pathway formulation thing. So, but
Are available for Free on the web.
So they are generic.
It's a good thing.
But the problem is going to be if I'm a practicing doc and I have 200 molecular entities. We heard earlier this morning somebody talked about we prescribe 100 in our practice. Well, if we have 200 or 300 molecular entities that we're trying to deal with, I'm going to have a tough time keeping up with what do I do? What do I do if 2 months into this somebody gets mucositis? Do I stop the dose? Do I reduce the dose? Do I stop and wait? Do I do it every other? So the knowledge is going to come in how do we manage and decide what's a toxicity of the therapy and what's a toxicity of the disease. And how do I do that as I have enough trouble just seeing breast cancer patients sorting that out. It's going to be very difficult as these teams who are trying to see everything sort out what's the disease.
But how are you going to use
This is where I think big data can come into it and say, look at this, of the 400 people around the country, we go to CancerLink or Watson or we go to Flatiron or whatever it is at that time.
Maybe Siri will be able to figure it out.
Or Siri goes and says, okay, of the 400 people who were treated, 2 of them were in Iowa, 2 of them in Michigan, 2, agglomerated, this is what the collective experience is.
But let's talk about it. So you got pathways and the 80%, pathways cover 80% of people, patients. So, but are you going to read in 5 years your Foundation of Molecular Health or your NO1 or KEW report, that's sent back on the patient that, whose specimen has been run through the, NGS platform or whatever, and, everybody's seen them. You have the recommendations and the list of, and you should consider this because there's been an association in the literature between this and this and this. And we're going to go to you next, Barry. I mean, is this coming? And so I remember 3 years ago, the year of personalized medicine is here. Well, in non-small cell lung cancer, only 15% of patients have, treatment directed by specific mutations, rearrangements, or protein expression.
But now there's 50% of non-small cell lung have some sort of mutation that's detectable today. They're not all druggable,
right.
But it's probably 15 that have a druggable mutation. But my colleagues show me 50% have some sort of mutation.
So for those 35% of patients that aren't druggable, how fast can pharma produce the agents that basically can be driven by those mutations, rearrangements, et cetera?
I mean, Bill, medicine is not something we can look back historically and observe economic cycles and suggest that this is what's going to happen. We are literally in new territory, and we're finding our way into being able to treat populations of people for things that never had treatments before, and effectively, and with downstream consequences that have just never been observed before. So we're finding our way through this stuff. I think that no one is prognosticating that, precision medicine will dictate every treatment decision in 5 years, but it certainly is a main effect that will be in play. We also know that there's a tremendous amount of value coming in this oncology portfolio. It is less mature than many of the other drug markets. And by 2022, most of the bulwark products that we have been relying on and been happy to have received in the last decade will either be generic or will have a biosimilar alternative. And there's tremendous amount of motivation to bring those alternative treatments to market. That will produce a fundamentally different marketplace than the way drugs were launched in the 90s and the first decade of this century. It is a more competitive marketplace. It is a harder marketplace in which to launch drugs. And so by bringing in this information revolution, the diagnostic technology evolving, we need a revolution of clinical operational technology. These things coming together result in an unpredictable equation, but boy, it's one that's exciting. And we have to believe that good things will happen unless we get in its way.
So, will the equilibrium, as it's established between, new generics, biosimilars, patents expire obviously, biosimilars, versus innovative agents coming on the market versus, again, biomarkers that drive clinical decisions. Will that equilibrium kind of solve our cost issue?
I believe that. We have no historical grounds necessarily to point to say this is the margin of error into which that will fall. And yet, as has already been stated, I simply don't believe that medical costs will be 50% of household income, and then it'll be 100% of household income, and then it'll be 150% of household income. Because that simply will not happen. We are dynamic, and we're not linear, and we are living systems, and we're reactive. And so long as we maintain certain parameters of fair play and transparency, this market will innovate itself into value. Innovation, I believe, leaves value in its wake.
And I think the example, I mean, many of you, well, I observed the 5-HT3 antiemetics before we had them. So the first one came on the market, had a premium price. Second one came about the same price. Third one came about the same price, but then I ran a practice at that point, and we started to get offers to, if we had market share, we could buy at a discount. That third one came along. And then the second one said, oh, okay, we can match that discount. So when you have price competition, so when you have multiple entrants, and I don't know what the magic number is, maybe it's 2, maybe it's 3 entrants in the market, you can get price competition if, and this is where I think the pathways, there's room for, they will be convergence, but there may be divergence. You say, okay, this pathway has this on it, and if we have 80% of people following this pathway, if we're allowed to innovate, as Dr. Fortner says, we'll be able to say, okay, we can do it cheaper, this pathway with this buying deal, and we can provide this episode of care at a price, and that I think is at least part of the solution where I think we need to go.
Well, I mean, we could go into that whole ballgame, and we've had discussions where you said, Bill, we have to keep it simple. But I want to make an announcement to the audience, but I'm going to come back to you about the question about the equilibrium between biosimilars and generics versus innovation, and then basically, biomarkers that are going to drive decision-making in terms of, I'm sure your company, in terms of forecasting, looking at premiums, looking at cancer care costs, has a concept here. So in about 2 minutes, if you have questions or comments, I believe people have microphones. I hope so, yes. Just raise your hand, and you can get into the discussion with questions or comments. And if you have criticisms for me, I like them. It makes me feel much more at home. So anyway. So I have all these lines. But anyway, Dr. Malin.
So, I think that it's going to continue to be an exciting time. I agree with Barry on that point. I think that the marketplace, though, right now is out of balance. If there was an article just a couple days ago in the New York Times, and this is something we've observed as well, in the last year, the cost of generic drugs has increased, generic and branded drugs, but also generics, has increased over the last year by 40%. So I don't think just having generics and biosimilars, if we don't have a marketplace that ensures that the pricing strategies for these therapies is based on the outcomes and safety profile of the drugs, and to your Merriam-Webster definition, the usefulness of the therapy. I think if you have a marketplace where, all the therapies can increase their price in 1 year by 40%, something is not right. So hopefully things will swing back and we'll get, more reasonable pricing that'll be affordable, so we don't end up with 80% of our paychecks going to our health care.
But if I agree with you, Jen, the market is distorted. But part of that is because the players that came in and said, we're going to drive, ASP 6 months, and that.
Well, this is AWP, though. This is not on the infused product side. This is on the
okay,
oral.
fair enough. But some of that is, it's more. This water was probably more expensive than 5-FU because of the downward spiral put in place by the ASP pricing methodology.
I agree. ASP is different. This is like insulin increasing by 1,000% in the last year?
Well, because you need to have that you need to have some margin. I'm not going to carry the drug company's water.
Bill, if I could make one comment on this,
please,
because
Barry.
it's a subtle point, but I believe that it's a very important point. Some of the metaphors used about healthcare in America, that it's broken, it's out of balance. I really don't look at it that way. I look at healthcare in America as evolving and developing. And that sounds like semantics, but it has profound implications for what you do about it. If you believe that physicians or patients or hospitals or payers or employers or the government is ill-willed and that it has to be controlled, then you do one thing. But if you believe that as the science progresses, a physician and a patient will choose the better outcome, and if you believe that as information becomes more readily available, physicians and patients will consume that information and use it in their best interest, then you reach a very different conclusion about healthcare in America, and you do something different in the marketplace today.
Okay, we have a question, I think, but my last question to the panel is going to be, and you know, it's where the rubber meets the road, and we started off, the audience wasn't in here yet talking about it, but so under the system, whether it's a combination of your managed care company, you know, the physician network you're in, the oncologist you see or have to see or whatever, just a one-sentence answer. Can you live in an absolute manner with the decision that would come out about the access and availability of needed treatment for a loved one? Okay? So basically, you know, obviously you're a beneficiary of Anthem.
Yeah, no, I mean.
So wait a minute, now that's,
sorry.
so let's go to the audience here. But I need a one-sentence answer, because I'm a time nerd. Don't we have a question? Oh, yes, whoever.
This is Linda Bosserman. So Barry, I would say that what we could expect is aligned incentives for patients' health, and hopefully that's where we're going to move. And I think as part of that, I want to congratulate Jen. You might want to mention both ASCO's value position, but what Anthem is doing to actually develop effective tools beyond the glossy brochures that most of us get, so we can detail physicians on the actual outcome of trials, the actual toxicities, and the actual cost, because I think patients deserve that.
Jen, do you want to? Oh.
Yeah, I appreciate the comment.
Okay.
And listen, I would say something. You know, Dr. Malin, I think, you know, finds herself in a debate. One of the things I would applaud you for, Dr. Malin, is being transparent about the pathways. One of the things that I hope the healthcare system does evolve on is creating clarity and insight into areas that currently can be held hostage, frankly. And those are the pools, the eddies in which bad things can happen. And the more transparency we get, then I believe the better side of human nature can show itself.
Yep. Yep. Do we have, yes, down there. Don't worry, I'm a time nerd. I know I got 300 seconds.
All right, Barbara McEnany, 2 comments. One is, I think the value of pathways is to aggregate enough patients into one treatment regimen that you can actually determine the quality by outcomes rather than the worthless PQRS and other metrics we're all clicking the boxes about, and be able to then look at first efficacy, then toxicity, and then cost, and hopefully be able to get rid of the prior authorization hassle that we go through if we use pathways. I think that's their first value. I think the second value is decision support, because to Doug Blaney's point about needing help with knowing all of the latest genomic biomarkers that are coming down, if we can embed those in pathways, it will help us to make sure that we do the right thing for the right patient, and maybe more importantly, not give an ineffective drug to that patient. I'd like comments.
Barbara, I agree. I think the issue is that I tried to make about the pathways is the toxicity and how do we manage things 2 or 3 down the road, months down the road with drugs that somebody may use once a year and not have the experience that somebody that uses them 5 times a week uses. And I meant to say, I didn't mean generic, I meant they're commodity. Pathways are going to be transparent and will be a commodity at some point.
Do you think that just hit a funny bone or something with me? Are pathways really guidelines, transparent? I think every pathway or whatever or guideline that's put together, the meeting should be public. Can you imagine the educational value of having, say, the world's leading experts sit around a table and discuss the data? Anyway, I mean, are any of the pathways, is anything out there really transparent? Everybody talks about transparency, we put our conflicts of interest up online, but I mean, are any of them really transparent?
Well, this is what again, I'm not a physician, but I think that many of the things that we do now to save money actually work off of patient ignorance. They work because patients don't know what they're not getting and who decided what they're not getting. Now, that's not to say, however, chemotherapy...
I would argue that many things that cost the system money
exactly
are
right.
ignorance, right? So do patients know that the pharma rep stopped by and left samples and detailed the practice?
Right. So it is a blade that cuts both ways,
Right.
but that's where we're going. And the fact is that chemotherapy is very toxic, and in the absence of reasonable scientific data to suggest that there's a positive benefit, that chemotherapy is a deleterious iatrogenic effect, consequence. It's a negative consequence. Patients don't understand that. So the information revolution will shore up both sides of this argument.
One of the choose wisely had to do with dual agent palliative chemotherapy and breast cancer. Another one had to do with chemotherapy. Don't choose wisely. Don't use chemotherapy in poor performance status patients. So forcing that issue, okay, well, what's the data? Well, okay, at least we forced the issue to discuss it. Now let's develop some data that suggests that, and that we can be transparent and have that conversation across the table with the patient.
So they were flashing, so I need your one-sentence answer on, it can't be a lawyer's, runaway, whatever they call those things, sentences. So, again, in an absolute manner, under your payer, whatever system you're in, and I'll start with you, Barry, would you accept the process that's in place to decide what the appropriate treatment is, or what the appropriate / available treatment is for a loved one, in an absolute manner, so you can't question it? Yes or no?
No.
No.
It keeps me getting up in the morning to make it better, so yes. I live in a system where we're constantly learning and constantly improving, and that's what keeps me going in the morning.
Okay, Dr. Malin?
My goal every day is to develop our system and to improve our system so that when people call me up and ask where they should get care, I know that they're going to be well cared for.
Okay, I asked for one sentence. We appreciate a round of applause for a great expert panel here. Great job, and we hope you enjoyed it a little bit. I didn't use as many of my old worn-out lines as usual, but anyway, thank you for being a great audience, and thank you, panel. It's a good thing.